Playing Jeopardy, right?
All right, so you can begin with good. All right, ladies and gentlemen, thank you for taking your time to be with us here tonight. We're going to start with a roll call attendance. So when you hear your name, please say present. Thank you.
Ackerman. Yeah. Say you're here.
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 It's you gotta wipe it. I think it's blurry. Okay. Pick it up and set it down one more time.
Here.
Andrew Dahl. Jeffrey Raybridge. Reed Caldwell. Jonathan Berkowitz. Eric Buttinger. Paul Barbara.
Present.
David Finelli.
Here.
Christine Chen. Mary Foote. Mark Cantor.
Here.
Ed Jarvis. Joseph Bowe.
Here.
Jessica Van Voorhees. Here. Benjamin Zabar. Benjamin Zabar is excused. He will be, his alternate will be Dr. Langley.
Here.
Matthew Paris.
Here.
Daniel Eckroth. Robert Krupe.
Here.
Carson Cooper.
Here.
David Yulangso. Adam Gottlieb.
Here.
Terrence Loud.
Was it at the computer?
All right, we do have a quorum, so we will.
Michelle, excuse me.
Yeah, no.
I think she called her, I would call his name, but I don't know where I heard her.
Oh,
Right?
Dr. Avicoli is here in the corner.
Yeah, she is here.
All right, so they're here. There. Dr. Avicoli is by the coffee machine, and Dr. Silius just sat down at Dr. Costco. All right. Thank you. So first, let's begin by approving the minutes of the February 10th meeting. There was a correction made to the minutes. Dr. Benelli, correct?
Correct. Yeah, they were
So
correct.
everybody had a chance to look at that. They were resent out with the correction.
Oh, no. That was
Questions?
those were the minutes for the January meeting, and they were just posted already.
Correct.
They were approved.
And they were approved, right, but the corrected version is approved.
The corrected
on
version was
on
approved in the
website.
meeting.
Yes,
Right.
it was fixed on the website. Yes,
Exactly.
it was approved as correct.
Correct. And the February 10th meeting, any questions, comments, concerns? Hearing none, we will entertain a motion to approve. Yes, anybody else? Matt, thank you. Okay, executive committee did not meet.
Facing up?
Yes. I will go to correspondence report now. So,
facing them?
Yeah, correspondence that I'm going to mention, there were no action items by the state, and CMAC and SEMSCO did not meet. We did receive an email from Dr. Seda on March 11th appointing Dr. Redlener to the new FDNY physician as an alternate physician member on this committee, and a letter from the Greater New York Hospital Association appointing John Vega, who was an alternate, to Dr. Redlener's seat. So Dr. Vega, thank you, and you can vote. Be heard. Thanks for joining us. Other than that, there were no other correspondence. Any questions about the correspondence? None? We'll move on to subcommittee reports, starting with Dr. Barbara, certification credentials.
Okay. You ready? Certification credentialing met on March 5th, and we'll be meeting again on April 2nd, virtually. Current action items, there are no forwarded motions from the committee to this group, but current action items include the deployment of a REMAC exam prep course, which is being piloted, and some advancements to the exam, including more visual questions for the collective group to have an understanding, like more visual stimuli questions. But other than that, nothing to report on, waiting for the protocol updates to incorporate into the new exam. Mr. Ward?
I have nothing.
Any questions for Dr. Barber? All right, hearing none, we'll move on. I just want to point out for everybody, on the agenda, the tag reports were moved to a separate section. So if it is a tag that is being discussed at your committees, we're going to discuss them separately afterwards. So you don't have to discuss those, but Dr. Benelli, the medical standards report.
Okay, thank you. Duly noted. So medical standards met 2 weeks ago, virtually. There were no protocols that are being brought as second in motion to REMAC, other than from the last meeting, but from the meeting before, there are still 2 protocols that need to be approved. And we will, I'll bring them up in the end of this report for discussion. The REMAC, the medical standards meeting had quite an extensive discussion regarding the tag committees, and I will not repeat it over here because we will discuss them again separately. There were questions, concerns, updates, and I'm sure we will talk to them. We'll talk about them in a little bit. Let's go to the protocols that need to be approved. I'm going to pull up the first protocol. Let me just see if we can do this and make it happen. Maybe not. Okay. So you received in your email these protocols. Let me just open it in Word in case I need to enter into any changes. Okay. And I'll try to make this a little bigger. Okay, so the first protocol that's being brought as second in motion is the non-traumatic cardiac arrest protocol. The only section in this protocol that requires update is in section 14. So for not working very well, Joe. Okay, so flickering away, but for section 14, administer epinephrine, 1 milligrams IV, 10 mLs of a 1 to 10,000 concentration. And the additions of this to this section are that for non-shockable rhythms, asystole and PEA administer as soon as possible. And for shockable rhythms, VF and VTAC administer after the second attempt at defibrillation. Repeat every 3 to 5 minutes until patient achieves return of spontaneous circulation loss. This is brought as second in motion from medical standards. If there's any discussion about this changeling.
Any questions?
Dr. Kaufman.
So I guess there's a motion to, just for clarity, we talked about removing the word non-shockable rhythms and shockable rhythms. So just for asystole PEA, administer as soon as possible. And then for VFVT, administer after the second attempt at defibrillation.
So is there anyone who seconds that motion?
So the discussion is whether to remove the language non-shockable rhythm and just have asystole PEA, or shockable rhythm, just have T50, T3T. Is that correct?
Yes, I mean, the discussion is that people know will determine what's shockable and non-shockable. I mean, it's kind of duplicating here. So we should just be clear.
No, I definitely agree with you on that, but the question is, should they know that BT is a shockable rhythm and that asystole is a non-shock rhythm, and we just need to leave non-shockable and shockable, or is it the other way around? I'm just for
It's fine by
discussion.
me.
I-
It's not a big point, it's just.
I see that you don't need both, but
CLS is really. That's a thing. Thinking down everything consistent with regard to whether you have to pull up on the ACLS app. Or
right, so but ACLS does list it as shockable and non-shockable. It doesn't specifically say assisted PDA and BFID.
but that's not here, just because you have it in parentheses after it.
So the motion was to remove that part,
Yeah.
correct?
Yes,
So what we're saying is that would be the motion that Brad made, and correct me if I'm wrong, was to remove the language shockable and non-shockable and leave asystole PDA and BFID BFAP. So the language that is consistent with AHA.
so, yeah, I mean, that is the motion.
Okay.
I don't think it's a big deal either way. I'm just trying to put forth some discussion.
Listen,
Yeah.
again, I think we should be consistent.
For sake of discussion, we all agree, you probably should be consistent with ACLS.
Yeah.
It talks about shock and non-shock.
Yeah, I go through those.
All right, so that's fine.
Okay, I'm sorry about the flickering, I don't know how to fix that.
That's expected.
Brad, we should just make sure that he's, whatever language.
Perfect, okay.
So,
If we look at, I mean, again, I don't have the AHA language in front of me, but if you look at AHA language, does it say non-shockable asystole PEA, or does it just say non-shockable? I think it should match whatever they're saying. Because at the top of the protocol, the first line is follow the AHA.
Wire.
Well,
No, what happened? I don't know.
so,
So it goes from CPR to rhythm shockable, that's no. BFBBT basis and B. So start off. It really is.
That has,
The algorithm, the check rhythm, the shockable rhythm, yes.
thank you.
Yeah, make
it has the same language that we have.
Oh, it looks like, all right. I should have compared to the AHA before. That was just a suggestion. We work out clarity. It's a bad idea.
We need something. We need something.
Good discussion.
All right, so
Let's hear that discussion.
I guess we can withdraw that.
Yeah. This discussion.
Any other discussion on that change?
Yeah, it's better.
I just want you to know that we did discuss this here, and we believe that these changes are not stuff that needs to go to the state. These are more clarity
I'm gonna go back to
and not
that.
changes.
The white thing,
Here.
yeah, I'm trying to get them, see if it flickers this.
You want to look on these as a whole, mass, there are no changes here.
No, no other
Flag
changes.
goes to the state. So I have no problem with going through them all and then voting it.
So we're done with this protocol. This is the only change for this protocol.
Okay, so let's vote on it. So it's the non.
So what is the, just so the protocol as is, not
Has it?
okay. I do want to bring up there was another concern of Dr. Zabar that
It's not here.
even though it's not here,
It's not
He's
here.
been excused, so.
As a non-voting member, can he raise a point? This is a point of parliamentary,
It's an open.
Go ahead.
Anybody can
Make your
discuss.
point.
Go ahead, fire away.
so
in his voice though.
his concern is if it is clear that ALS should immediately give epi for shockable rhythm if there have been previous analysis that did not show shockable rhythm. So I'm just bringing that up there here for discussion. I can repeat that. So the concern is if there were two before ALS arrived. I'm sorry?
You're saying BLS did.
So BLS put them on an AED, there were two non-shockable rhythms, and then ALS survives, and now they have shockable rhythms. What should they do first? So that was the question.
Training.
Wait.
Yeah,
The question is, what should they do with a shockable rhythm?
yeah, they should shock. I mean, there's no.
I'm just restating the question.
Yes, that's right.
No snark.
No, no
Probably
snark.
should press the
That
button.
wasn't
There's a
necessary.
snark in that.
No snark at all.
We
Never.
can say that snark for Ben.
I'm sorry, the question.
Yeah, I don't really, I mean, if they have shockable rhythm, they should shock.
Yeah, I agree.
Should we check with the AHA?
I'll just say I think let's see,
Maybe I don't understand.
and that's what I thought, I was trying to clear up some, there's not much confusion, but if there is,
Sorry.
if medics get them, is it clear that medics should immediately give epi? If already two shots, I think that was the concern.
So I would propose that that's a training issue, that the medic can arrive and realize where we are in this algorithm that was moving. And if BLS has already done certain steps, they should go to the next step, right? They should take over wherever the call is at.
I just,
It's illogical, because that's what you did.
I don't know. I hear what you're saying, Brad, and it seems to me a little bit of like we're starting to get into the what if season. If we can make a protocol that's advantageous for the what if.
I agree.
Yeah,
So I think that it's, I think we're telling them what we want them to do.
I agree. This is a training issue and, you know, and I think that, what Dr. Barber said, if you have a shockable rhythm, you have to shock. And, you know,
I'd like. As long as this part back to protocol, the next time they look for protocol, if we consider mapping the number of records, that will certainly take 5 minutes, but for some research. You know, you probably should see endlessly giving it an records. Just a suggestion for protocol. I don't want any amendments.
It's not to what we're talking.
I know.
Use looping, Greg.
Just give us a suggestion.
Make
sure you speak into the mic.
So we're gonna vote as is. Vote.
So I just wanted to make a suggestion that this protocol is reviewed again, or maybe we should look.
You hear better
consider
now?
Evidence for capping.
Yeah, I hear now.
Not proposing any amendments now.
Let's vote then. All right, so we're gonna vote on the cardiac arrest protocol, results as you see it in front of you.
sometimes, occasionally you see it.
All your names, please say in favor. Vote, abstain. Salcedo,
Okay.
Kathy Kaufman,
in favor.
Jerry Gonzalez, Eddie Merson,
Right.
Emma White,
Okay.
Chris Wertzak,
Okay.
Jeffrey Rayburn,
In favor.
Paul,
Yes.
Roger Cooper,
Yes.
Ed Jarrett, Mark Sanchez,
There.
Tom Fisher, Karen Fuller, in favor. Bob Hope, Steve Saliers, in favor. Ben Voorhees,
I hear her partially. Yeah.
In favor.
Paul Barber,
In favor.
Danny Benelli,
In favor.
Nick Kuchar,
All right, Dr. Benelli, we're back.
Okay, let's move on to the next protocol. One second. Okay, so the next protocol is the Strider crew protocol. Again, let me just open it up in Word so we all on the same page. So there are a couple of changes over here. First of all, in section 3, we eliminated the concept of blow by oxygen. Okay, we just removed that from the from the protocol. It should not be. The patient should receive oxygen. For the NP section 7, request ALS assistant if the patient is missing. has mental status changes or evidence of shock. So that's what we has over here. Then in section 10, obtain IV access only if there are signs of respiratory failure or shock. The rationale behind this is really to try to avoid agitating a child unnecessarily when there are other available options. And that leads to section 11. For pediatric patients ages greater than 6 months, and this is an update from Dr. Harris. It used to be 2 years, it's now 6 months. Administer one of the following medications, any of the following medication, one of the following medications for any of the following conditions: stridor at rest, respiratory distress, or persistent bodily cough. So, and what's happened over here in the options is that we changed the option A to prefer PO if possible. Okay, so administer dexamethasone 0.6 milligrams PO, IM, and IV. So again, in an attempt to try to avoid agitating the child too much, and again, for methylprednisolone, IM and IV. Section 12, if there is clinical concern for epiglottitis, do not attempt advanced airway management and ventilate using the BVM. That kind of makes sense. We removed the comment over there, see key points and considerations. Medical control options, again, the age was adjusted to 6 months. And then in key points, again, some wording changes really. So first key point, again, adjusting the age to 6 months and greater. The next key point, epiglottitis is rare, but should be suspected in an ill-appearing child with stridor retractions, muffled voice, high fever, tripod positioning, or drooling. Sorry that it's flickering. And we moved off toxic appearance because we were concerned that people might not be able to identify what exactly toxic appearance appears, particularly if the child is known to be unvaccinated, and then the rest remains the same. Next point essentially is the same. The other 2 points were removed. The other 3 points were removed. That's just about it. Any discussion about this?
Any questions? Any discussion? All right, so here you go. Yeah, Dr. Harris.
Just a quick comment that I think is more targeted for, as we bring this back to education. This is just to, what I think again, the flip of the script that this is epiglottitis told proven otherwise, and this is really proof 99 out of that. So I just think it's go back to our respective ambulance services. This is really to take this, don't touch the kid. This is overwhelming. Likely the best education perspective.
Any other comments? All right, if not, we're going to vote on the protocol as it's written on the screen.
I also believe this protocol is not it's mostly just as that said clarification.
Attorney is in favor, opposed, or abstaining.
Okay.
In favor.
It's Ross.
Okay.
Anderson.
Yes.
Lloyd.
In favor.
Christopher Bissett.
In favor.
Augustus. Deputy Raver.
In favor.
Movie itu Pak do Halia.
Well,
Yes.
Gilbert.
Yes.
Carpenter.
In favor.
In
favor.
Foley.
Better.
In favor.
It's better.
Andrew Harris. In favor. And Zabo.
Favor. In favor.
Yes.
All right, we're gonna move on to Dr. Benelli. Anything else from medical standpoint?
No, that concludes the report from medical standards. The next meeting is on April 14th, 3 p.m. virtually. Thank you very much.
Thank you. All right, so the Q&A committee did not meet, therefore we will skip their report for now and head up to the next meeting. We'll move on to training and education, Mr. Lax.
Meeting that met on February 27th. The biggest, sorry. Trying to admit, on February 27th, the biggest item was the July first protocol rollout. So we mapped out a two-part training. One part is going to be just the red line items, and the more significant ones, such as the one that Dr. Harris just discussed, will be done by video, which to this point of what you should be taking back to your agencies. He's going to work with us to make a video so that that does go to all the agencies and goes directly to them. So that will be very, very clear. We've been partnering with regional CME providers, one of the Rio to Vegas Water, the Ocean of the Sun, to get their content recorded when they do it so that we can put it on the LMS after the fact and still offer CME credit for it with a test afterwards. There's a gap analysis that we've been trying to work on between our protocols and the protocols so that the providers enter for each other. We will have that available for them in the form of some sort of package that will either live on the LMS and or the website so that it's quick and easy for them to get. They can take whatever the relatively limited course will be and bring that back to the agencies so that there is a standardized way for everyone to up to date on regional protocols, especially new EMTs, those coming to the region. The BLS side is done. The ALS side is going to be a pretty heavy lift, so it's going to take longer. Regional faculty, there's going to be a certified instructor update on March 29th at the Healthcare Expo at EMC. And we are going to be helping training that's going to be helping out Whitestone Volunteer Ambulance, whose state cert got restricted, or I should say it was just recently reinstated, I should say, and we're going to help them with providing CIC to get them up and running and syringe epinephrine and optometry, which requires any of them. We're also collaborating with the New York City Alliance Against Sexual Assault on a survey tool that's going to be followed by some associated training that they will be providing to the region, and they're still waiting for follow-up to that survey tool. Next meeting is this Friday.
Questions for Mr. Lack? Hearing none, we'll move on to RTAC. We did not get a report for that. We'll move on to the tag report. The STEMI tag, Dr. Isaacs is not here. I know that we are in the process of finalizing the three main groups to discuss the STEMI tag, and that those groups will begin meeting shortly. So that is all in the works. If anybody here is interested in being part of that, please reach out to me or to Dr. Isaacs. Ultrasound tag. I know that Dr. Zimmerman isn't here, and the last meeting has not been for a significant amount of time. There was a brief discussion at Medical Standards about an ultrasound project. Dr. Benelli or Dr. Barber, do you want to talk about that?
Dr. Barber, what's
Happy to take questions.
Yeah, that's what I mean. I don't know that everybody here knows what we're talking about, so maybe introduce what we're talking about, and then we can have questions.
Okay. So let me just pull up the document here. There is a pilot set forth by the REMAC regarding the integration of pre-hospital ultrasound in the region. And having been part of those meetings and in transparent discussion with the TAG chair and the REMAC executive leadership, we at Staten Island University Hospital began a pilot on pre-hospital ultrasound. Essentially working out the case of a quality program with the understanding that deploying a novice sonographer with no credentialing in the in the skill and also no formal integration of education in their certification at the state level, that it would be dangerous to start with the sonographer being a paramedic. So we're utilizing our emergency medicine residents who've already gone through a credentialing process with our RDMS trained ultrasound academic faculty to obtain images for transmission and not for the purpose of patient care decision making. This pilot was approved and started about a month and a half ago. We're on our third resident carrying the probe with feedback. I think we've done about 6 or 7 ultrasounds at this point. And the purpose is to identify the ruggedization of pre-hospital ultrasound more than the clinical decision making. I'm happy to answer any questions about it as needed, but that's kind of where we are.
So this sounds
No,
like.
we did that like over 20 years ago.
On how
What?
effective it can be used and
Ultrasound.
transmitted from the field. Not
Fees-
effective
How
clinical
I did that.
decision.
Feasibility of
Get it working.
identifying a quality program for the eventual use of feedback of the sonographer. Essentially, right now, the scans are mostly incomplete, which would lead to trouble and, if it was deployed for clinical decision making. And also, much like we have, EKGs in the field versus EKGs in the hospital, any program, I think, utilizing hospital-based ultrasounds to train paramedics will probably be not what they would encounter in a real life experience. So as these devices get better, the goal is to see what they can really do for practicality.
Questions for Dr. Barbara or anybody else?
What indications are they using the ultrasound for mostly?
It's a great question, Doc. So it's essentially lung arrest, shock. So when I taken a couple of the protocols and inserted yes/no decisions into where things could be, turned into essentially a simple decision. I'm a big fan of simple decisions with ultrasound as opposed to let's put the probe on and see what we find. So it's differentiating dyspnea, asthma, COPD, wall motion abnormalities, pericardial effusion, pneumothorax and shock, and pneumothorax and wall motion in arrest. No IVs, no bellies, no fast.
Any other questions?
Are you guys using one specific ultrasound or are you trialing different types?
Another great question. We were offered a device on loaner and we couldn't utilize it because the cloud was not amenable for patient identification. So we're using a device that we already have, a company we already have a contract with. And it's their ruggedized device that's being integrated in image storage capacity as essentially our rolling cart ultrasounds to be reviewed in the same fashion. So we are only using one device. But there are devices out there that will offer you a device if you want to try it. It didn't work out practically.
So your choice of the things you're studying are those that can change management, right? Essentially, lung,
Yes,
Yeah.
yes.
shock.
Well, that's
No,
what
they're
I
all
asked.
very
Are they actually
emergent.
changing?
That's it.
Are they actually changing their management? Like, are they terminating CPR based
No,
on?
we're not doing anything different. It's
Okay.
completely blinded.
Okay,
Right now, we're in image acquisition only. Transmission, image acquisition, review by the sonographer and feedback, review by the sono faculty and feedback to the sonographer. There's nothing to do with patient care. In fact, if the paramedic doesn't want the probe on the truck, the resident puts it away for the shift.
okay.
So it's completely inert compared to EMS medicine as declared by the paramedic.
So
And
they're
it's
still
not-
diagnosing pneumothorax clinically, like, do they hear lung sounds? Is there signs of
It's
tension?
as if the probe wasn't on the truck
Got it, okay.
and only in transit.
Any other questions?
Thank you.
Thank you. All right, the ultrasound tag is chaired by Dr. Zimmerman. If anybody here would like to participate, I would reach out to Michelle or Dr. Zimmerman and we can get you on the tag and be put. Okay. The last tag that I have listed is the RSI implementation tag, which is chaired by Dr. Barbara. So let's kind of have a discussion. I know that Included in the paperwork that was sent out was the draft of the standards that we're gonna look at. Include the minimal standards for training, the responsibilities of the agency, the training requirements, and so on. So why don't we talk a little bit about this? Barbara, if you wanna just bring it up to the table and then we'll talk.
On behalf of that subcommittee, I'll present our collective working. Essentially, the subcommittee came up with minimum standards for what an RSI authorized paramedic would look like, responsibilities of an RSI agency, and training requirements. In our last medical standards meeting, a lot of discussion was, were brought to light, which was helpful for the collective growth of the region. And it's my understanding that the next best steps would be to work on a collective airway training program, which would be a critical part of any RSI program, whether it's 2026 or 2046. So based on concerns about deployment and training requirements, my understanding from the meeting was that we would be moving forward with identifying stakeholders to build an airway training program. And RSI itself would be put on hold. The criteria are essentially very closely mirroring the Suffolk County criteria. Maybe some people in the room who,
And others.
who have something to do with a program that's already functional that we can utilize those best practices on. But the working compromise is developing an airway training program, regardless of our RSI is to take off.
And any feedback on the document or comments for Derek? Yeah.
I thought part of our last discussion was to look at the baseline of what we're doing now. Start to evaluate paramedics and how successful are in patients and assessment. We did that at the start. Correct?
No, so that did come up at medical standards. We are compiling that data at the same time. We're just bringing information from other regions as to what an RSI program would look like. Now, again, this is looking at what are the standards for training, what would we need to do to implement a program like this. It might not pay if we look at our data and see that we're 100% first pass success, then we clearly don't need an RSI program. But I think the things are happening in conjunction. Paul?
Regarding the concern of what the success rates are, I don't know how that looks, and maybe someone can help me understand whether that's agency-based, region-based, how practical and achievable that data is. I feel it's an obstacle to an obvious need that any work we start with, if it deploys on figuring out something we may already know, I don't understand how that is implementable. I just don't understand it. Is it regional or is it agency one?
I think it's a little bit of both, but I think that if we look at the data and see that we're really, really good at intubation, I know we're not, but I'm saying, if let's say we looked at the data and it showed that we're really great at this, then we don't need an RSI program. On the other, especially with all the costs involved in training and all the different things. So we want the data as a starting point, but at the same time, looking at what other regions are doing and how to develop a program makes sense. Now, that's I think part of the discussion that we're having is that I agree with Dario. We need a kind of a benchmark. At the same time, we should still be considering what would it entail to put something like this in practice. I mean, I use RSI in another region, and I know that the training requirements are very high. I know that Dr. Bove uses it in Suffolk, and it's when you have a smaller cadre of medics that you can really oversee much tighter. It might be different than in a city like we have, where we have a little bit of a larger population. It's just a thought.
But that, you answered your own question.
What do you mean?
So you just said there's two different types of agencies and probably a spectrum in between.
Correct.
What does that first piece of information that we clearly need to know? What the first pass success rate is? What does
I'm
that
using
look like?
first pass success as one marker. I don't think it's the only marker that's important.
Certainly, but what I'm asking is like, what's achievable? Can we come back to this meeting next week and go around the room and everyone give their success rates?
No, to your point, I think, right, this may not make sense for every agency, right? Not every agency in a region will do it. So to your point of where we're looking at regional data, yes, right? So like agency, you have to look by agency too to say, hey, this doesn't make sense for my agency because we're either really good at intubation, my guys don't have enough intubation, whatever it is, right? Where you say, hey, we do need it at this agency because we have a problem here that we want to fix.
So Dr. Ray,
Yes.
like we can deliberate what's the first step over and over again. If we don't know what the first step is, how can it be the first step?
They're both the
They're
first.
both, right, the first step is this.
The first achievable
What
step
you've
is an
done-
airway training program.
What you've done is put together this document, which I think is good guidance, and what you're saying, develop a training program is makes sense, right? And at the same time, we can look by region, by agency and say, who does this make sense for, right? It may not be everyone, right? In other regions where I guess it's not every agency, it's not every medic.
Suffolk County the same way. It depended on the service. We have about 100 RSI medics. That's what we have.
And they probably
Out of how many?
No, no.
100 out of how many?
It's like
I don't want to make it up, but
It's like 1100 in the
10%.
800, 9.
So about
It's not
10%.
easy to do.
Not
You
even
have to go
10%.
through a rigorous program.
Yeah, and that's the point. There's a lot of work in maintaining it.
Not everybody does it.
But makes sense.
That makes sense.
Another question, medical standard meeting was for that you, for the opinion of quite a few, was that one piece about the different standards. Because now you're saying it might not be for everyone, right? I get it. And then, Joe, you're telling me 10% of your medics are sub-true.
Right.
So that's not the reason. So that's another argument, especially we need to have, because it's very difficult when we're talking about standards. You want it to be all 18 regional. And I'm here right now, so that's not the case.
Yeah, I agree with you, and that's, so I'm just providing, where I think we're giving experience of what we do in other regions, and that it's an enhanced skill, basically. Right, it's like an added credential, like you have rescue medics, you have some other special, certain populations. I think that to say that this is a skill for everyone in a region as large as ours is fraught with a lot of issues, problems, so you're right. I think we have to look at it very carefully.
Because the medical standard meeting was not.
Yeah, no.
So, to be clear, and I'm gonna answer what Glenn is saying specifically, I do agree that, and I did say this at the medical standards meeting, I think that we should have a regional standard. That's my personal opinion, not, and again, I chair a committee of everybody here. So if the majority of everybody says it doesn't have to be a regional standard, we can have selected medics that are trained in RSI. I am 100% in favor of the group consensus. I personally like the idea that knowing that if you send a medic to a job, it is going to be a certain standard. I will tell you that there is challenges to not having a uniform standard, and we might have to address these, as Grace can tell you, when we have to deal with different regions, different neighborhoods, having different levels of care. If somebody were to see that, they will make this a PR nightmare for everybody. And that happens when we had the stroke ambulance, like you mentioned, and there was a whole to-do that to go through that. So it is something to consider, but I agree. That is my opinion, that we should have one regional standard. If the opinion of the rest of the group is there are medics that can be rescue medics without the whole region, I agree with the group. I mean, I'm only one person.
It's just
Art
another
had a
tool.
comment. Hold on one second. Let's let Art speak, and then Joe, and then.
Thanks. So, I may be a dinosaur. You are, but let me repeat that for the crowd. I may be a dinosaur.
Yes.
But it seems to me that our traditional practice has been to utilize intubation only when other methods of airway control were not effective.
it as a matter of actual everyday practice, that means if the patient cannot be effectively ventilated, the bag and mask would go right to intubation. Now, that then, this is now, we now have available to us options. Okay, that, you know, that can be placed simply and easily with a very high of success by a wide range of providers. And the ability to check end-tidal CO2 to make sure that the patient's being adequately ventilated. Why are we putting emphasis on something like, you know, rapid sequence intubation, okay? Which is rarely going to be needed, and we're going to have an impossible time training everybody to the level that needs to be trained. You know, why do we not use a methodology we know works, measure end-tidal CO2? Yeah. Okay, and if that fails, even though it's a very, very high rate of success, far higher than first pass with intubation, for sure. Okay. Okay, maybe then we can consider that. But you know, to me, we should be moving toward active mass ventilation followed by IGEL measuring end-tidal CO2. And if and only if that fails, moving on to intubation. Thank you.
You might be we might be talking about apples and oranges. It's something kind of use it on the helicopters. Because it's a little bit limited amount of space, the patient has to be stable, rock stable. So they're the ones that get it for sure. In the field, it's just another tool in the toolbox of the medics. They have a difficult airway, or they think if they paralyze, they'll get more success. Our success rate's in the 90-something percentile. So it works when the decision is made correctly. That's all. Again, I think there's different apples and oranges between our transport time, your transport time, helicopters, things like that.
Joe, I'm not talking about Suffolk. I'm talking about New York City.
No, but I'm trying to show you where it works.
I understand.
Yeah, so for my point, I just want to address Glenn's point, because I think it's a very valid point. But I think it opens up more considerations, right? So yes, make it a standard for the region. I'm not necessarily opposed to that. I just think that's a different calculus of what's involved than, you know, doing it as an additional, like other regions do, a credential, you know, by med. If we're going to say it's standard for the region, just from a QA, from a training, from that point of view, more work. That's all. I'm not saying it's wrong. I mean, it may be the way to go. It's just something to consider as we discuss this.
Yeah, and I understand what you're all saying, but the last understanding, you make it all sound like this is the you know, that this is really the standard of care, which is not, right? Okay, so it's in the National Register training and the bottom. So we're not doing. You all see what make it sound like this is the standard of care, and then talk about Suffolk County, and I'm finding that 10% of your medics are credentialed.
It's not standard, but it's not standard of care, Glenn, you're right.
No, but that's what was said before. I mean, we can pull this back up, but it wasn't just standard of care because it's in the training curriculum. I don't agree with it. That's my opinion. And 10% of your medics are trained in RSI. I'll tell you right now that we have medics that are not into it. They go right to the IGEL. About 10%. So that number is very confident. And as Art said, it is very successful.
We love that.
And we looked at our protocol, and first we're like, why didn't you attempt to intubate? It doesn't say you must. Even cardiac arrest, if you have a manageable airway, you can be VM then. Sure. We can't tell them you shouldn't, right? So now with the glide scope, I think, as I said in understanding, you really put Dario a past meeting about get the data. And I said that last time as well. I think that we should definitely be looking at the data as well. Here. Let's look at it. So, I mean, why come up with this kind of training curriculum where let's look at the others first. I think that's the first thing. Like that.
Yeah, I think that the conflict here is really, you know, on the one hand, I think we all want our paramedics to work up to the scope of practice and get adequate training to do so. But I want to back up, I think, what Ryan and Arbor said. Certainly, you know, from the PEDS perspective, recognizing the RSI proposal here is not about steroids, but you know, there's an active and probably going to be the largest, you know, prospective pediatric airway trial right now called PD Park, which is pretty close to completion, which is going to show definitively that IGLs, which are provided over the the least of PEDS, is going to be the recommended, right? Advanced of the device. And I think that even, you know, Wang and his colleagues, his other studies have just shown it's easier for everybody, for adults and for getting quicker, minutes quicker. And so I do think that this is another interesting tool that I think warrants further discussion, but I think it becomes a tool, toolbox, not the new tool. I think it's the works. I think it's, part of it.
Any other comments?
Can we get to what the data looks like this meeting or maybe in the next one?
What do you mean by that?
So I'm vying for progress. So we started out with a plan to talk about protocols and treatment. And that was felt to be collectively not appropriate, not ready, or it was services immature or whatever. So a compromise was made in the last meeting for discussing training. And here we bring that here and collectively, legislatively, we've decided that that's also not okay. So taking the need of the group here, what does a success rate program for data look like? I challenge this group to come up with what that looks like so we can start moving forward.
I'm just gonna ask this. Is your question, what are the markers that we should be looking at? What data points?
Data points, is that
what you're saying?
whatever this group wants to move forward?
I'm just asking,
I don't know. That's why I'm asking. I also don't know.
I would say that, things that I mean, yeah, I think we should discuss this, but things that I would consider important in looking and evaluating our airway management is first pass success, time on seat. These are the things that I think are very relevant, in monitoring CO2. These are the things that are important when we monitor airways, correct? I don't know if you're looking for a specific marker or a specific.
So we said this at one of the earlier meetings, and the quality chair said it was not sustainable for the region to obtain quality data on intubations.
We have this. Most agencies have airway one markers. We have.
Certainly. So let's collectively come up with an academic and professional answer to what the success rate looks like. That way we can work towards achieving it as opposed to deliberating content.
I don't know what you mean by success rate.
Don't want to check success rate. I know the success rate is probably 50% or less region-wide, and I think there's opportunity for growth. But we have identified stalwartly that we need to know what our data is. I don't want to act like I'm being told I'm ridiculing anyone again. But we've identified that we want data. So I asked, the audit committee doesn't know how to obtain that. What does that look like with this collective group of leaders?
Yeah.
So you can use Gamma, right? Gamma tracks all ground and air, and they have the metrics for airway. But anybody, if you look them up, first pass success, definitive airway, so they have metrics that you can look at to measure. The question then becomes, what's the hypothesis? Is a poor success rate, need for?
Yeah, I think that we're not even talking about hypothesis yet. Gary makes a very good point. Where are we now? We should know what our thinking is now. What is our success rate? What is the length on seat, time on seat?
Just how many intimations are we doing?
Exactly. These are the basic data points that would tell us if it's changes to the best in our entire program. That's serious. Gary, would you agree with that?
I don't agree. If you don't know where you're starting, what do you want to do?
Or there seems to be.
We have the same meeting.
Broad disagreement or impasse or whatever it is on RSI. But I think the consistent point that all physicians have been making at all of the meetings about this is that there are poor intubation success rates. I think that's where the idea to develop some sort of training, push training. Yeah, Dr. coming here and saying that should I don't disagree, but we're moving further and further away from intubation, where there are patients that still need to be intubated, and the agency leaders here are saying that we have more success rates. So whether we go or not, let's train them to do better. That's the point about training.
Yeah, airway about it.
Yes.
Yes.
Yeah. So we're not sure to go our side, at least the food training. So the innovation. But take it away and you stuck with us, I don't, then we're not helping, but.
All right, so we're gonna ask the QA committee to come up with 5 metrics that we can use to benchmark where we are in the region on innovation. That sounds reasonable? Joe?
Just to give the committee an update on it. So the QA committee has developed a series of benchmarks in airway that they are looking to implement. We're in the process right now of vetting some vendors, analytics vendors, to do this work on behalf of the committee.
Perfect. Great, I love it.
So hopefully we'll have an update for the next meeting.
Perfect, I think that's a great point. Excellent. All right, well, and listen, I think this is a good discussion. I know that, you know, RSI is not the standard, by the way. The standard is what we say in the region standard is. That is what legally we're held to, is what our protocols are. And you could make an argument that it's the gold standard for airway management. I don't even know if I agree with that. But I think it's good to have this discussion. I think that anything we can do to improve airway management is a positive thing, whether that means better training, whether that means better tools, whatever it might be. I think it's a good discussion. So thank you. And Paul, this document is actually very good. And I think we can use this once we have those benchmarks and goals that we want to set up. Any further discussion on RSI, or can we move on?
I just want my colleague, Dr. Cooper, to know I'm from the Jurassic era too.
Speaking to the mic, or else speaking to the mic.
That those protocols are on stone tablets.
Yeah, it's chisel, stone tablets, yeah, mine are on wax.
Wow. A pirate.
We're partners
All
in
right,
crime, you know that.
let's move on. Regional council update, Dr. Cooper.
Okay, so the Regional Emergency Medical Service Council of New York met on January 17th here. Approved the motions. Move the appointment of Michelle P. Bastag as the Golden representative of Trevor Hassola. Move the appointment of Justice Carpinta, as New York City University and Older representative. Approved the transfer of operating authority Mercy Ambulance Service of 8th to Missouri 41, and operating authority Prince County, East of the Vanderbilt Expressway. Ambulance Service. Approved staff for the New York City REMSCO Lifelong Children Board. This one will be named beyond Dr. Langston will be recognized as total recipient at the of the weakness to be served on. Just something I was First affairs update during the nursing strike, committee requests voluntary mutual participation, multiple notification distributed voluntary agencies, encouraging 911 system participation. Audience the first participate in the feature and the activation, approximately 12 is hundred test. Most department responsible for coordinating the response to the trial period, the system mobilizing investigators, illnesses for resolve. The office now receives copies of agency renewal applications from your state UH to maintain updated regional contact databases. The office continues to participate in the Greater New York Hospital Association, Heritage coordinating to initiatives. On February 22nd of this year, the U.S. Toronto hosted a private meeting, CNY, New York, Internet, Town Halls in partnership with the MCC, the Kimbrough, the College, the approximately 75 virtual and 12 in-person attendees participating. The session was recorded and will be posted to YouTube at KBLS. A workforce website is being developed to outline the between paramedic pathways, credentialing steps, and the scholarship opportunities, including the Dr. Easy Scholarship. For organization update, for fiscal year 25, the information contract. The second quarter can be fiscal year 25 payment until December 2024. And the receipt or funding remains approximately 16 months behind full line. New York State Department of Health continues to accept vouchers, the processing timeliness remains consistent. Budget restructuring is underway to address problematic line items. Further important that updated deliverable descriptions are anticipated following upcoming CMAP meetings. The meetings planned with the FDNY program is to review and align MOUs to associated deliverables. Analyst Committee Volunteer Assistance Tag is providing inspections, support, and regulatory guidance to volunteer agencies in the region. The recruitment and retention tags advanced issues, including community interconnect, senior certification graduation development, and workforce survey development. The QA on hospital tag is Or individual policy, the CBA policy 06/06, and director of each security for review. The Office of Regional Council open nominations for analyzed regional council members and for regional council officers. Staff can send out, I think it's already on out. Email with nomination template, what forms should this can submit names. Application for regional national boards, is that easy, paramedic scholarships is now open. Next week, the council meeting will be March 31st, 2026.
Any questions for Dr. People? So that, the nominations for awards was due on the 17th. We did not get a significant amount of awards, so if anybody in your agency, anybody that you work with, you think is appropriate for an award in the region, please let us know before tomorrow, so that we can get that processed and on the agenda for the REMSCO meeting. Okay. Any other questions? So there's no unfinished business, is there any new business? Seeing no new business, I will entertain a motion to adjourn. All right, thank you. We'll see you in April. And again, EMS week dinner is on the 17th of May, I believe, which is Sunday. That Russo's on the Bay. So can participate in the whole deal.
A friendly reminder, tomorrow's the deadline to submit applications for awards. Another reminder.
What's up, Cindy?
You have to do a certain number of meetings, right? Like a year to move to membership in good standing. There's 7 meetings this year, right? And you have to, you can't miss how many, like.
So
Cancel too, right? Or am I making that out?
yeah, well, and cancellations don't count, right?
Yeah.
So we hold 8 meetings weekly generally. Can't miss one.
And you could hear him winding up. It's like,
That's like.
That's what
It's crazy. I don't want
Yeah, that's, I think you want the Greece and that's, yeah, it's crazy.
You tell Ben to return.
Yeah.